Welcome to another deep dive. Today we're taking a deep plunge into a fascinating, often misunderstood, and really increasingly relevant area of infectious diseases. We've compiled a rich stack of sources for this, including a really comprehensive look at non-tuberculous mycobacterial infections. That's chapter 180 from a leading medical textbook, alongside some crucial context on neglected tropical diseases. Our mission today isn't just to skim the surface. We're going to truly dig in, aiming to master this information so you understand it with the clarity and depth of, well, top professionals in the field. We'll be meticulously unpacking everything, the epidemiology, the intricate biology, the diverse ways these infections manifest, how they're accurately diagnosed, and crucially, how they're prevented and treated.
And that level of understanding is vital here. While many people are familiar with tuberculosis, the classic TB, the bacteria we're focusing on today, non-tuberculous mycobacteria or NTMs, well, they're actually far more common in many parts of the industrialized world. Yet they often fly completely under the radar. Grasping the nuances of NTMs can truly be an aha moment for anyone looking to be truly well-informed in the realms of public health and medicine.
Okay, let's unpack this. To begin, let's set a broader context by understanding a category of diseases often found in the shadows: neglected tropical diseases, or NPDs. This concept is incredibly important for grasping why NTMs, despite their growing prevalence, can be so easily overlooked. What exactly defines an NTD?
That's a great starting point. Neglected tropical diseases represent a truly sobering category of treatable infectious diseases. What defines them isn't just their geographic prevalence, though many are found in tropical regions, but rather the fact that they are consistently well neglected. This means they receive disproportionately low attention in public policy in terms of funding and, critically, in the development of the diagnostics and treatments that could transform the lives of those affected. These diseases impact some of the world's most vulnerable populations, yet struggle to gain the necessary attention and resources.
And our sources use leprosy as the archetypical NTD. It's a powerful example because it embodies all those characteristics you just mentioned, doesn't it?
Absolutely.
It's treatable. We know precisely the population at risk, and there's even preventive chemotherapy available. Yet the physical complications from leprosy can still lead to severe, lifelong disabilities. And beyond the physical, there's this deeply entrenched social stigma that causes discrimination, social exclusion, and often severe mental health consequences for those who are affected. It's a disease that highlights not just biological challenges, but profound societal ones.
Right. What's truly striking about leprosy and what makes it such a potent example of an NTD is the paradox you alluded to. Despite being treatable and having a known pathway for intervention, we've understood how to treat it for decades, the priority given to leprosy on the public health agendas of most endemic countries remains remarkably low. It's a systemic issue, reflecting the very meaning of neglected. Historically, efforts focused on early case detection and multi-drug treatment. But despite these focused, what we call vertical programs, the transmission of the bacteria, Mycobacterium leprae, hasn't been interrupted in communities as effectively as hoped. And in many places, the incidence just hasn't declined sufficiently.
It sounds like a deeply frustrating cycle. That's why the concept of a joint collaborative approach for NTDs is so powerful. Instead of individual siloed programs for each disease, the idea is for health organizations to join hands. Think of it as a united front in advocacy, fundraising, and developing shared control strategies. Can you elaborate on how this collaborative model might work and what its broader benefits are?
Absolutely. This collaborative approach can significantly raise the overall priority profile of all NTDs, benefiting each individual disease control program by leveraging shared resources and awareness campaigns. But it goes deeper than that. By working together, these efforts can strengthen health services more effectively than isolated vertical programs ever could, ultimately serving the broader goal of universal health coverage. Imagine a health system that's robust enough to tackle multiple neglected diseases simultaneously rather than fragmenting its efforts. It's just more efficient.
It sounds like a much more holistic and, sustainable way to approach global health. And speaking of broad strategies, the World Health Organization, or WHO, has formulated a new global leprosy strategy for 2021 to 2030. What's central to their vision for achieving zero leprosy?
The WHO's new strategy is quite ambitious, focusing on a holistic approach. Zero infection and disease, zero disability, and zero stigma and discrimination. These aren't just aspirational goals, they have very specific targets. For example, they aim for 120 countries to have zero new autochthonous leprosy cases, meaning cases originating within that country by 2030. They also target a 70% reduction in new cases detected annually and a 90% reduction in new cases per million children. This isn't just about treating illness, it's about a profound societal and public health transformation, moving towards truly eradicating the disease and its social consequences.
That's a truly ambitious vision. What are some of the key innovations or strategies being deployed to achieve these zero leprosy goals?
Well, a key strategy to achieve these zero leprosy goals is the widespread implementation of what's called post-exposure chemoprophylaxis, or PP, using a single dose of rifampin. This is a significant innovation. A large randomized controlled trial demonstrated that giving a single dose of rifampin to household and other close contacts can reduce their risk of developing leprosy by about 60%. Implementation studies have further confirmed that this approach is feasible and generally well accepted in communities. Our sources also mention promising vaccine candidates like the MIP vaccine from India and the synthetic Lepvax vaccine from the US. If proven effective, these would be used as post-exposure immunoprophylaxis, similar to how the BCG vaccine, which already provides varying degrees of protection against leprosy, is used for contacts in Brazil.
It's clear there's a multi-pronged attack strategy here, but what are some of the broader challenges or critical considerations for endemic countries trying to implement these strategies?
Yeah, if we connect this to the bigger picture, achieving zero leprosy truly depends on endemic countries enhancing their control activities across the board. This includes not just treatment, but active case finding, improving diagnostic methods, screening the contacts of those infected, implementing PP, and providing better disability prevention services. And crucially, it involves sustained activities to reduce stigma and promote social inclusion and mental well-being for those affected. What's particularly concerning, and a key insight from our sources, is the acknowledgement of a significant threat. With waning interest in leprosy and its integration into non-specialized health systems, the number of medical professionals experienced in diagnosing and treating leprosy has decreased worldwide. Regaining that lost expertise requires renewed energy and resources, reinforcing the need for integrated health systems strengthening rather than isolated, disease-specific programs. It's a real challenge.
That point about expertise being lost really hits home, reminding us how quickly a disease can slip under the radar. And speaking of overlooked pathogens, let's finally zero in on the main focus of our deep dive. Non-tuberculous mycobacteria themselves. What exactly are we talking about when we say NTMs?
Okay, so when we talk about NTMs, we're broadly referring to mycobacteria other than Mycobacterium tuberculosis, which causes the classic well-known form of TB and its close relatives like M. bovis, M. capreae, and M. africanum. We also exclude M. leprae, the cause of leprosy, which we just discussed. In fact, you might hear NTMs also called atypical mycobacteria or environmental mycobacteria. The key is they are distinct from the organisms causing those two major diseases.
And what's truly groundbreaking here is how our understanding of these organisms is rapidly evolving. Our sources tell us the number of identified NTM species is growing incredibly fast, now exceeding 199 known species. What does this rapid growth in identified species really tell us about NTMs, and what are the practical implications of being able to differentiate them so precisely now?
Well, this explosion in identification is largely thanks to advancements in molecular biology, particularly DNA sequence typing for speciation. What it tells us is that the NTM family is far more diverse than we once thought. The practical implication is huge. We're really refining our ability to differentiate these individual species. And that's absolutely critical because different NTM species can cause very different types of infections and, crucially, respond to different treatments. It moves us from a broad, general understanding to a much more precise, targeted approach to diagnosis and therapy. It's like going from guessing which key opens a lock to having a precise set of keys for every specific lock.
That makes perfect sense. And beyond their sheer diversity, our sources also highlight their incredible adaptability. What does that mean in the real world for how these bacteria survive and persist?
What's also notable is their remarkable resilience. NTMs are incredibly hardy. They can inhabit amazingly hostile environments, even industrial solvents. Yeah, it highlights their ubiquity and their sheer toughness. They're found naturally in soil, water systems, even in our tap water. This makes them such persistent organisms in the world around us, meaning we're constantly exposed to them in our environment.
So we've established that NTMs are incredibly adaptable and ubiquitous. That naturally leads us to the question: how do these organisms, found literally everywhere, interact with humans, and what are the patterns of infection? Let's dive into their epidemiology.
Well, the core information here is that NTMs are indeed ubiquitous. You find them widely in soil and water. However, and this is the key point, despite their widespread presence, they rarely cause a disease in humans unless there's some impairment of the host's defense system or a breach in the body's natural barriers, like through a wound or maybe a medical procedure.
That's a crucial distinction for listeners. It's not like you just breathe them in casually and get sick. Our sources emphasize the rarity of human-to-human transmission. The notable exception mentioned is in certain settings, like among cystic fibrosis patients where it can occur. Otherwise, you're generally not catching NTM from another person, which is a major difference from, say, tuberculosis.
Right. And this brings us to a significant challenge for public health and clinical practice. Reliable incidence and prevalence data for NTM infections are sorely lacking. Why? Because these infections are rarely reported to health agencies, and their identification can be problematic. This lack of reporting poses serious issues, especially when clinicians are trying to distinguish NTMs from M. tuberculosis during therapy for suspected TB, particularly when relying on initial screening methods like acid-fast bacilli smears. A positive smear could be either, you see. And without precise species identification, it's a diagnostic dilemma that can lead to misdiagnosis and inappropriate treatment.
So, if tracking these NTMs is such a challenge, what are we actually seeing in terms of where they're causing problems and who is being affected? Is DNA sequencing truly the game changer it seems to be in helping us understand this dynamic?
Oh, absolutely. The increasing ease of identification and speciation thanks to advanced techniques like DNA sequencing is having a major impact. This isn't just an academic exercise, it's dynamically changing our understanding of the global epidemiology of both tuberculosis and NTM infections. We're getting a much clearer picture of what's out there, allowing us to see significant geographic and demographic shifts.
And that clearer picture reveals some stark contrasts. For instance, in the United States, the incidence and prevalence of pulmonary NTM infection are now several-fold higher than tuberculosis. And while classic TB rates fall, NTM rates are actually increasing, especially among the elderly. That's a profound epidemiological shift, isn't it?
It truly is. This shift means that what was once a relatively obscure group of bacteria is now a major public health concern in industrialized nations. And when we look at specific organisms, our sources tell us that in the U.S., the bulk of the disease is due to Mycobacterium kinsaceae, organisms of the Mycobacterium avium complex, or MAC and M. abscessus. Looking globally, Europe, Asia, and Australia show a similar distribution with MAC and rapidly growing organisms like M. abscessus. But in Northern Europe, for example, M. zinopi and M. malmoens are particularly prominent, so you see these regional variations in which species are most common.
And then there are those more localized presentations you mentioned earlier. Can you give us a sense of where those specific NTMs tend to crop up?
Certainly. In tropical zones, particularly Western Africa, Mycobacterium ulcerans is responsible for Buruli ulcer, a very distinct and frankly devastating skin infection. And in coastal regions or among individuals with significant water exposure, think people with fish tanks or who frequent swimming pools, or even those who work with fish. Mycobacterium marinum is a common cause of cutaneous and tendon infections. These are great examples of how environmental exposure often dictates the specific NTM species encountered.
And as you mentioned earlier, it's critical to differentiate an active disease that actually requires treatment from simply commensal harboring. Just finding the organism doesn't necessarily mean it's causing illness.
Yeah.
How do clinicians make that distinction?
That's a key challenge. Our sources note that the American Thoracic Society, or ATS, has developed a widely used scheme for the proper diagnosis of pulmonary NTM infection. This scheme helps guide clinicians in making that crucial distinction. Because NTMs are so ubiquitous in the environment, you might pick them up without them ever causing a problem. The ATS guidelines provide criteria to determine when the presence of the bacteria truly represents an active infection that needs intervention. It's about context.
So we know NTMs are everywhere, but our bodies usually fend them off. That leads us to the crucial question. How do our bodies actually battle these organisms, and what happens when those defenses aren't quite up to the task? Let's delve into the intricate pathobiology of NTM infections.
This is where the immune system comes into sharp focus, and it's truly fascinating, because exposure to NTM is essentially universal. I mean, we encounter them constantly, and serious disease in healthy individuals is incredibly rare. We can assume that our normal host defenses against these organisms are incredibly strong. This also means that if someone does develop significant NTM disease, it almost always implies that specific susceptibility factors are present, allowing the NTM to establish, multiply, and cause illness.
What are some of those key immune players that are so critical in this defense?
Our sources highlight CD4 plus T lymphocytes as crucial effector cells in controlling mycobacterial infections. We saw this starkly at the advent of the HIV epidemic. The development of disseminated NAC disease was highly correlated with a significant decline in CD4 plus T cell numbers. This correlation has also been observed in patients with idiopathic CD4 plus T lymphocytopenia. That's a rare condition where CD4 counts drop without obvious cause. This powerfully indicates that a robust CD4 plus T cell count is a significant defense.
That makes intuitive sense. A weakened immune system leads to vulnerability. But beyond the sheer number of immune cells, what about specific signaling molecules? I understand tumor necrosis factor alpha, or TNF-alpha, plays a vital role.
Yes, what's truly illuminating here is the role of tumor necrosis factor alpha, or TNF-alpha. This is a critical cytokine. Think of it as an immune messenger protein essential for mycobacterial control. Our sources give us a powerful illustrative example. A class of potent drugs, like infliximab or adalimumab, work by neutralizing the cytokine. While they're used to treat other conditions, a significant consequence can be the inhibition of granuloma formation. Granulomas are like microscopic, walled-off fortresses the immune system builds to contain infections, essentially trapping the bacteria.
Okay.
When TNF-alpha is blocked, these fortresses can't form properly, occasionally leading to severe mycobacterial or fungal infections. This directly demonstrates how absolutely crucial TNF-alpha is in maintaining control over these pathogens within the body.
So if TNF-alpha is like the architect for these protective immune walls, blocking it means those walls can't be built.
Got it. But beyond these broad immune factors, our sources reveal a much more intricate genetic story about susceptibility to NTM. It sounds like specific genetic pathways are at play.
You're absolutely right. This is where it gets really interesting and incredibly precise. Much of the genetic basis of susceptibility to disseminated NTM infection, especially in cases where there aren't those broad risk factors, like advanced HIV, is accounted for by specific, identifiable mutations in what's called the interferon gamma, IFN, interleukin-12, IL-12 synthesis and response pathway. This is a critical immune communication network, almost like a command and control center for fighting intracellular bacteria like mycobacteria.
Can you walk us through how that pathway, this command and control center, actually functions? It sounds like understanding its steps is key to grasping where things can go wrong. Let's break it down, as beautifully depicted in diagrams like Figure 180-1 in our sources. It starts when mycobacteria are phagocytosed by macrophages. That's when these immune cells literally engulf and try to swallow the bacteria. Think Pac-Man. These macrophages then respond by producing IL-12, which is a complex molecule. IL-12 then acts on its specific receptor, a bit like a key fitting into a lock on other immune cells, leading to a crucial step called STAT4 phosphorylation. This STAT4 stimulation, in turn, triggers the secretion of IFN-NOT, which is another powerful immune signaling molecule. IFN-NOT is critical because it activates other cells like neutrophils and macrophages to produce reactive oxidants that kill bacteria. It increases the expression of molecules that help identify pathogens, and it concentrates certain antibiotics inside cells, all powerful defenses.
And the cascade continues, creating a feedback loop, right?
Exactly. IFN then acts through its own receptor, which leads to the phosphorylation of STAT1. STAT1 then goes on to regulate specific genes, the instructions for building proteins that are involved in the immune response, including those coding for IL-12 and TNF-MEC. This effectively creates a positive feedback loop, amplifying the immune response. And TNFN itself, as we discussed, signals through its own receptor via a downstream complex that includes a molecule called NEMO, the NFM essential modulator, to activate NFPA, another crucial pathway for inflammation and immunity. So you have this complex, interconnected system where IFNM and IL-12, IL-23 are the primary drivers of the immune response to mycobacteria and other intracellular infections. When a piece of this intricate wiring is faulty, that's when severe NTM disease can take hold.
That's truly groundbreaking that we're pinpointing specific genetic weaknesses, almost like faulty wiring in the immune system. What are some of the known critical genes within this pathway, and what does it tell us about cases where no genetic diagnosis is found?
Yeah, the ability to pinpoint these specific genetic mutations is revolutionizing how we understand susceptibility. Our sources list critical genes like IFNGR1, IFNGR2, STAT1, GATA2, ISG15, IRF8, IL-12A, IL-12RB1, IL-12RB2, CYBB. That one encodes a key protein for forming reactive oxygen species called GP91-FOX of the NADPH oxidase SPP2A, and IKBKG, which encodes NEMO. Mutations in any of these can lead to a vulnerability. However, despite identifying these crucial genes, only about 70% of non-HIV disseminated NTM cases have a genetic diagnosis.
Only 70%.
Right, which implies that even more mycobacterial susceptibility genes and pathways remain to be discovered. It's a field still actively uncovering its full complexity. We haven't found all the pieces yet.
So even with all this progress, there are still pieces of the puzzle missing. Are there other factors beyond this core pathway that contribute to IFN production or TNF upregulation?
Yes, it's not just one isolated pathway. Our sources mention that other cytokines like IL-15 and IL-18 also contribute to IFN production, acting as supporting players in that central immune response. And signaling through the toll-like receptor complex and CD14, which are like sensors on immune cells, can upregulate TNFM production. So it's a finely tuned network of immune interactions where many elements contribute to the overall defense.
What's fascinating here is that while this IFN-GAL12 pathway is crucial for disseminated disease, widespread infection throughout the body for pulmonary NTM infections, which are far more common, the best recognized underlying condition is something else entirely. Bronchiectasis. What exactly is bronchiectasis and why is it so strongly linked to NTM lung infections?
Good question. Bronchiectasis is a chronic lung condition where the airways become abnormally widened and damaged. This leads to a buildup of mucus and makes them much more prone to infection. Many well-characterized forms of bronchiectasis, including cystic fibrosis, primary ciliary dyskinesia, a genetic condition called STAT3 deficient hyper-IgE syndrome, and even idiopathic bronchiectasis, meaning the cause isn't known, show high rates of association with NTM infection. Our sources emphasize that bronchiectasis and NTM infection often coexist and can even exacerbate each other, creating a kind of vicious cycle in the lung.
So you have damaged airways, which then become a breeding ground, and the NTM infection makes the damage worse, creating this downward spiral. This raises an important question, though. The precise mechanism by which bronchiectasis predisposes an individual to locally destructive but not systemic involvement from NTM is still unknown.
That's right.
It's a key piece of the puzzle that researchers are still trying to solve, as it's not simply a systemic immune deficiency, like in the pathway defects, but rather a localized vulnerability in the lungs. Why there and not elsewhere? We don't fully know. Knowing the underlying biology and the body's defenses, let's now explore the varied ways NTM infections actually present in people. It's truly a spectrum of symptoms, and understanding these diverse manifestations is key to accurate diagnosis.
Indeed. We can start with disseminated disease, which, as we've said, signifies significant immune dysfunction. Historically, this was most notably seen in advanced HIV infection. Disseminated MAC or M. cansacea infections were quite common in these patients. However, a significant success story is that our sources note that in North America, these widespread infections are now uncommon. That's thanks to effective antimycobacterial prophylaxis and significantly improved HIV treatment that boosts the immune system.
That's a huge step forward in HIV care. When these disseminated infections were common, our sources indicate the portal of entry was often the bowel, leading to widespread dissemination to the bone marrow and the bloodstream. What's surprising, though, is that even in patients with advanced HIV, disseminated infections with rapidly growing NTMs like Mycobacterium abscessus or Mycobacterium fortuitum are very rare. This suggests these particular species might have different requirements for systemic infection. Maybe they're less invasive.
Possibly. Given their generally low intrinsic virulence, when these organisms do disseminate, it's almost always in conjunction with impaired immunity. The presentation is typically indolent and progressive. That means it develops slowly over weeks to months, often subtly. Patients commonly experience malaise, just a general feeling of discomfort, fever, and weight loss, often accompanied by organ enlargement, swollen lymph nodes, and anemia.
This sounds like it could be easily mistaken for other chronic illnesses, making diagnosis a real challenge. What's the critical step for clinicians?
The most critical step is simply suspecting an NTM infection, because special cultures or stains are required to identify the organisms. Routine blood cultures might even be negative, but involved organs typically harbor significant organism burdens, sometimes with a grossly impaired granulomatous response, meaning the body struggles to form those protective immune walls we talked about. This makes the clinician's suspicion absolutely vital, as mycobacterial labs operate separately from routine bacteriology. You have to ask for the right tests.
This raises an important point for clinicians. In a child, disseminated NTM involvement, meaning in 2 or more organs, without an obvious medical cause or procedure, well, that should immediately prompt an investigation of that IFN-IL-12 pathway we discussed earlier. What are some of the specific genetic clues that might lead a doctor to look for these particular mutations?
Right? Genetic clues are vital here. For instance, recessive mutations in IFNGR1 and IFNGR2, where you need two copies of the faulty gene, typically lead to severe NTM infection. In contrast, dominant negative mutations in IFNGR1, where just one faulty copy can cause problems, can lead to an overaccumulation of a defective receptor on the cell surface. This inhibits normal IFN signaling and uniquely leads to nontuberculous mycobacterial osteomyelitis infection of the bone marrow. Dominant negative mutations in STAT1 and recessive mutations in IL-12RB1 can also produce variable presentations depending on their residual capacity for IFN synthesis and response. It's complex.
And there are other genetic markers to watch for. It sounds like specific physical findings can even hint at an underlying genetic vulnerability.
Absolutely. Male patients with disseminated NTM infections who also present with unusual features like conical, peg, or missing teeth, or abnormal hair patterns, they should be evaluated for defects in the pathway that activates NF-Q through NEMO, or IKBKG. These patients might also have associated immune globulin defects, which compromise their ability to produce antibodies. And if you see patients with myelodysplasia, a type of bone marrow disorder, and mycobacterial disease, they should be investigated for GATA2 deficiency. Finally, a recently recognized syndrome, often seen in East Asian female patients, involves high-titer neutralizing autoantibodies to IFN-DATO. These are antibodies your own body makes that attack and disable a crucial immune signal. This causes disseminated, rapidly growing NTM, predominantly M. abscessus, and other opportunistic infections. It's a fascinating interplay of genetics and autoimmunity.
Beyond intrinsic genetic factors, there are also infections acquired from medical procedures. What are some of the ways NTM can be introduced into the body iatrogenically, meaning inadvertently caused by medical intervention?
There are indeed several iatrogenic causes. 4C catheters, for example, can become infected with NTM, usually from contaminated water used during their insertion or care. M. abscessus and M. fortuitum sometimes infect deep indwelling lines, as well as fluids used in eye surgery, subcutaneous injections, and even local anesthetics. Crucially, in these cases, the infected catheters or foreign bodies must be removed to clear the infection. Antibiotics alone often aren't enough. You have to get rid of the source.
Moving on to pulmonary disease, this is by far the most common form of non-tuberculous mycobacterial infection in North America and the rest of the industrialized world. The rates of NTM lung disease here significantly exceed those of tuberculosis, which is a major shift. What does this look like for a patient?
The clinical presentation is often quite insidious. Months or even years of persistent throat clearing, a nagging cough that just won't go away, and slowly progressive fatigue. Patients often experience a significant diagnostic lag. Our sources note it's about 5 years in older women because the symptoms are so nonspecific, they can be quite subtle initially. This can lead to multiple physician visits and temporary symptom-based therapies before the correct diagnosis is even suspected, delaying proper treatment considerably.
It's important to note that because not all patients can produce sputum for testing, bronchoscopy, where a tube is inserted into the airways, may be required for diagnosis in some cases. What are some of the underlying predispositions for pulmonary NTM infections?
Well, predisposing factors for pulmonary NTM are typically underlying lung diseases such as bronchiectasis, which we just discussed, as well as pneumoconiosis, lung disease from inhaling dust, chronic obstructive pulmonary disease, COPD, primary ciliary dyskinesia, a genetic disorder affecting airway clearance, alpha-1 antitrypsin deficiency, and cystic fibrosis. Our sources emphasize that bronchiectasis and NTM infection often coexist and can even exacerbate each other, creating that vicious cycle of damage and infection in the lung we talked about.
Among these, MAXE organisms are the most common causes of pulmonary NTM infection in North America, though rates can vary regionally. Our sources describe a classic presentation of MAXE infection, often called Lady Windermere syndrome. What did that look like?
Yes, Lady Windermere syndrome. It's a memorable term. The classic presentation of MSC infection often develops in the 6th or 7th decade of life, typically around 60 years old, in women who have had months or years of a nagging, intermittent cough and fatigue, sometimes with sputum production or chest pain. This constellation of pulmonary disease, particularly in a tall and thin, older, non-smoking white woman who might also have chest wall abnormalities like scoliosis, mitral valve prolapse, or pectus anomalies, it's quite distinctive. It helps paint a clear picture for clinicians.
That's a wonderfully descriptive term, Lady Windermere syndrome. Does this particular presentation, often in older women, reveal anything unique about how MSC interacts with the host, or perhaps how the disease progresses differently in this group?
It does hint at different dynamics. What's fascinating about MAs is the strain variation observed. While male smokers with upper lobe cavitary disease, meaning they develop holes in their lungs, tend to carry the same single MA strain indefinitely, non-smoking females with nodular bronchiectasis often carry several strains of MA simultaneously, and these strains can even change over the course of their disease. This suggests different host pathogen dynamics at play, possibly due to chronic inflammation and varying immune responses in the damaged airways.
And other NTM species cause distinct pulmonary presentations. I understand M. kansasi can strongly resemble tuberculosis.
Yes, M. kansasi, for example, can cause a clinical syndrome that strongly resembles tuberculosis, with symptoms like hemoptysis, coughing up blood chest pain, and cavitary lung disease. It can really mimic TB. Rapidly growing NTMs, such as M. abscessus, have also been associated with esophageal motility disorders like achalasia, a condition where the esophagus has difficulty moving food down. This shows how NTM can present in surprising ways beyond just the lungs themselves.
It's also worth mentioning that patients with pulmonary alveolar proteinosis are prone to pulmonary NTM and nocardia infections. What's the mechanism there?
Right. In patients with pulmonary alveolar proteinosis, the underlying mechanism may be the inhibition of alveolar macrophage function due to autoantibodies to granulocyte macrophage colony stimulating factor, or GM-CSF. These are antibodies your own body produces that attack and disable a crucial immune signaling molecule that macrophages need to function effectively. This again points to very specific immune vulnerabilities allowing these infections to take hold.
Now let's move to cervical lymph nodes. This is actually the most common form of nontuberculous mycobacterial infection among young children in North America, usually caused by amphi organisms, though other NTMs can be responsible too. What does this typically look like?
The presentation is typically a firm, relatively painless swelling in the neck region affecting the lymph nodes with few systemic signs like fever. Because the differential diagnosis for painless adenopathy swollen lymph nodes includes malignancy, many children with NTM infection are diagnosed inadvertently at biopsy. Often, cultures and special stains for mycobacteria may not have even been requested initially because mycobacterial disease wasn't high on the differential diagnosis list. The good news is that local fistulae, if they develop these or abnormal connections that can drain, usually resolve completely with surgical resection and port-or antibiotic therapy. Similarly, there's an entity of isolated pediatric intrathoracic NTM infection, meaning within the chest, which is probably related to cervical lymph node infection and is usually mistaken for cancer initially. What's important here is that children with these localized NTM infections usually do not have underlying immune defects and don't typically go on to develop other opportunistic infections. It's primarily a localized issue.
Next, we have skin and soft tissue disease. This usually requires a break in the skin for the bacteria to be introduced. Are there common scenarios for this?
Yes, definitely. A common example is pedicure bath-associated infection with M. fortuitum. This is more likely if there's a skin abrasion, like from leg shaving, just before the pedicure, providing an entry point for the bacteria that might be in the water. Outbreaks of skin infection are also often caused by rapidly growing NTMs, especially M. abscessus, M. fortuitum, and M. chelone, acquired via skin contamination from surgical instruments, particularly in cosmetic surgery, or from injections and other medical procedures. These infections typically present as painful, red, draining subcutaneous nodules, lumps under the skin, usually without associated fever or systemic symptoms.
And Mycobacterium marinum is a fascinating one because it lives in so many water sources. How does that typically present in humans?
It's quite common. You can acquire M. marinum from fish tanks, swimming pools, barnacles, or even handling fish scales. This organism typically causes papules or ulcers on the skin, often colloquially called a fish tank granuloma. But the infection can progress to tendinitis inflammation of the tendons, leading to significant impairment of manual dexterity. The lesions usually appear days to weeks after a minor trauma, like cleaning boats or handling fish, when the bacteria gain entry. What's striking is that tender nodules, due to M. marinum, can advance up the arm in a sporotrichoid spread pattern, similar to a fungal infection following the lymphatic channels. Carpal tendon involvement affecting the wrist tendons may even be the first presenting manifestation.
And finally, for skin infections, Mycobacterium ulcerans is another waterborne skin pathogen, mainly found in tropical areas. What sets its presentation apart?
Ulcerans is primarily found in tropical areas, especially in Western Africa. Infection typically follows skin trauma or insect bites that allow the bacteria access from contaminated water sources. The skin lesions are notably painless, clean ulcers that can slaw, meaning the tissue dies and falls off, and they may even cause osteomyelitis, which is a bone infection. What's really key here is that a toxin called mycolactone accounts for the modest host inflammatory response and the characteristic painless ulcerations. This mycolactone acts almost like a local anesthetic and immune suppressor,
Wow.
making the ulcers painless and difficult for the body to fight off effectively, which explains their often extensive destructive nature. It's quite a nasty toxin.
With such diverse and sometimes subtle presentations, how do we accurately pinpoint these elusive pathogens? Let's turn our attention to the diagnostic quest for identifying NTMs.
Okay, this is where laboratory detection becomes critical. NTMs can be detected on acid-fast or fluorochrome smears of sputum or other body fluids. These are special stains that highlight mycobacteria. If the organism burden is high, they might even appear as gram-positive beaded rods under the microscope, though this finding is unreliable for specific identification and isn't as precise as the acid-fast stain. It's also important to differentiate them from nocardia, another type of bacteria which can also appear gram-positive and beaded, but are characteristically filamentous, meaning they look like threads.
Here's the crucial step, and this is where clinicians truly need to be, well, elite professionals. The most sensitive step in diagnosing any mycobacterial disease is simply to think of it and include it in your differential diagnosis. Why is that initial thought so important?
Because in almost all laboratories, mycobacterial sample processing, staining, and culture are conducted separately from routine bacteriologic tests. So many infections go undiagnosed simply because the physician didn't request the appropriate mycobacterial test. You can't find what you're not looking for. Additionally, mycobacteria usually require separate blood culture media, which isn't standard in routine blood draws. This means a high degree of clinical suspicion is paramount. You have to suspect it to test for it.
And how are NTMs broadly categorized in the lab based on their growth?
NTMs are broadly differentiated by their growth rates into rapidly growing forms, which take less than 7 days to culture, and slowly growing forms, taking 7 days or more. For comparison, M. tuberculosis typically takes at least 2 weeks to grow, and many labs will wait a full 6 weeks for final culture results before declaring a sample negative. Fortunately, newer techniques using liquid culture media permit more rapid isolation of mycobacteria from specimens compared to traditional methods using solid agar. Things are getting faster.
And some species have even more specific growth conditions, making them tricky to isolate, right?
Yes, very specific. Our sources note that M. marinum, M. haemophilum, and M. ulcerans grow better when incubated at a cooler temperature of 30 degrees C rather than typical body temperature. M. haemophilum prefers iron supplementation or blood in its medium, while M. genevans actually requires a supplemented medium with a specific additive called mycobactin J. This level of specificity highlights the challenges in culturing some of these more fastidious NTMs and underscores why specialized labs are so important.
Historically, how were these organisms identified, and how has that changed with modern science?
Historically, identification relied on simple characteristics like pigment formation, whether bacteria formed pigment in light conditions, which we call photochromogenicity, in dark conditions, called scotochromogenicity, or lacked pigment entirely, known as non-chromogenicity. For instance, M. tuberculosis colonies are distinct: beige, rough, dry, and flat. However, current identification schemes are far more reliable and precise. We now use biochemical tests, nucleic acid analysis like DNA sequencing, or analyzing cell wall composition, often assessed by high-performance liquid chromatography or mass spectrometry for precise speciation identifying the exact species. Much more accurate now.
This shifting landscape in diagnostics is profound. What has it revealed about the prevalence of NTMs compared to TB now?
Well, with the remarkable decline in U.S. cases of tuberculosis over recent decades, NTMs have now become the mycobacteria most commonly isolated from humans in North America. This is a significant epidemiological shift. And this is a critical distinction, not all isolations of NTM, especially from the lung, reflect pathology that requires treatment. Just finding it doesn't mean it's causing the problem.
This leads us to the diagnostic criteria and guidelines. How do clinicians differentiate between a true NTM infection requiring treatment versus just the presence of the organism, especially on the lungs?
For a disseminated disease, isolation of the organism from a blood or organ biopsy specimen in a clinically compatible setting is generally diagnostic. It's quite straightforward there. However, for pulmonary NTM infection, it's more nuanced. The American Thoracic Society, or ATS, recommends diagnosis only when the disease is clearly demonstrable. This means you need an appropriate clinical presentation and radiographic findings like nodules, bronchiectasis, or cavities on imaging, and repeated isolation of NTM from expectorated sputum, or recovery of NTM from bronchoscopy or biopsy specimens. Both clinical and microbiological evidence are needed. It's a higher bar.
Given the large number of NTF species and the importance of accurate diagnosis for proper therapy, identifying these organisms down to the species level is ideally crucial. What are the specific ATS guidelines for common NTMs like MAC, M. abscessus, and M. kansasii?
Okay, the ATS guidelines for M. abscessus and M. kansasii specify clear criteria for pulmonary disease. You need growth from 2 of 3 sputum samples, regardless of whether a smear was positive.
Okay.
Or a positive bronchoscopic alveolar lavage sample, again, regardless of smear.
Right.
Or a pulmonary parenchyma biopsy sample showing granulomatous inflammation, those walled-off immune responses we discussed. Or mycobacteria on section plus NTM on culture. These stringent guidelines ensure that treatment is only initiated when there's compelling evidence of active disease, not just colonization. And these guidelines likely apply to other NTMs as well, though the data for them might be less robust.
Another significant diagnostic challenge involves the tuberculin skin test, or PPD, and interferon gamma release assays, or IGRAs. The PPD test, also known as the MAN2 test, uses purified protein derivative from tuberculosis to evoke a memory T-cell response. Why doesn't this test differentiate well between some NTM infections and M. tuberculosis infection?
That's a great question and a common point of confusion. Unfortunately, the PPD test uses proteins that are shared by M. tuberculosis and some NTMs, so it doesn't differentiate well between them. Intermediate reactions, around 10 millimeters in duration, that's the hard swelling, can overlap significantly. So if someone has a positive PPD, it could be TB, or it could be exposure to certain NTMs. It's not specific enough in that range.
So as active tuberculosis declines in places like the United States, NTMs probably account for an increasing proportion of positive PPD reactions. Plus, the BCG vaccine, used against tuberculosis, can also cause some degree of cross-reactivity, complicating the interpretation for vaccinated individuals. How do IGRAs, which are supposedly more specific for TB, fit into this?
Well, IGRAs, on the other hand, measure the IFN response to relatively tuberculosis-specific proteins, ESO-T6 and CFP10. They are generally more specific for M. tuberculosis because these proteins are largely unique to TB. However, some NTMs, such as M. kansasii, M. murinum, and M. sulgi, can also express ESAT6 and CFP10. This can lead to false positive reactions in IGRAs, again blurring the diagnostic lines, although less often than with PPD. Despite this cross-reactivity, it's worth noting that large PPD reactions, say greater than 15 millimeters, most commonly still signify tuberculosis. Conversely, in the setting of those anti-IFN autoantibodies we discussed earlier, the IGRA test can actually be indeterminate, showing a failure of IFN at detection because the antibody is blocking the very signal the test measures, so even IGRAs have limitations.
Turning to imaging and biopsy findings, the radiographic appearance of NTM disease in the lung can vary based on the underlying disease, the severity of the infection, and the imaging modality. But the advent and increased use of CT scans have really revolutionized diagnosis. What are some characteristic findings on CT?
Oh, absolutely. CT scans give us much more detail. This is where we see findings like the tree and bud pattern of bronchiolar inflammation, which is highly consistent with NTM infection, as depicted in figures like 1HEAD22. It looks like small branching trees in the lung, indicating inflammation in the smallest airways. CT scans also allow us to see involvement of specific lung lobes, like the lingual and right middle lobes, which are commonly affected but difficult to appreciate on plain film chest x-rays. In more advanced disease, severe bronchiectasis and cavity formation are common, indicating significant lung destruction.
Isolation of NTM from respiratory samples can sometimes be confusing. For example, Mycobacterium gordoni is often recovered from respiratory samples, but it's usually not seen on smear and is almost never a pathogen, so finding it doesn't necessarily mean disease. Patients with bronchiectasis might also have NTM recovered from sputum culture with a negative smear. What does that mean for diagnosis?
Yeah, M. gordoni is often just an environmental contaminant. A negative smear with a positive culture in a patient with bronchiectasis means the bacteria are present, maybe in lower numbers, but they could still be contributing to disease. This highlights why following the ATS guidelines is so important. It's not just about finding the bug, but finding it in the right clinical context and with enough evidence of actual disease activity.
Biopsy is often crucial for definitive diagnosis. What makes it such strong evidence?
Isolation of NTM from a biopsy specimen provides strong evidence for infection because you're getting it directly from the affected tissue. However, cases of laboratory contamination can occur. So, identification of the organisms on stained sections of the biopsy material, meaning actually seeing the bacteria within the affected tissue under a microscope, is really important to confirm the authenticity of the culture findings. It proves it wasn't just contamination. It's also worth noting that some NTM, like M. tilburgier, remain non-cultivable. They just won't grow in the lab, but can still be identified molecularly in clinical samples. This is a testament to advancing diagnostic techniques that don't rely solely on traditional culture.
Finally, let's talk about susceptibility testing. Speciation, as we discussed, helps determine the appropriate antimycobacterial therapy. However, the utility of in vitro susceptibility tests for NTMs is quite limited compared to other bacteria. Why is that?
It's a key challenge, and frankly, a bit frustrating sometimes. Our sources state that only testing MSC organisms for susceptibility to clarithromycin and M. cansasi for susceptibility to rifampin is actually indicated based on current evidence. There are very few data to support other in vitro susceptibility tests, those tests done in a test tube or petri dish, despite how attractive they might seem to clinicians looking for guidance. They just don't correlate well with how patients respond in many cases.
What's a useful general rule for clinicians regarding MA susceptibility?
Well, what's fascinating here is that MA isolates that have not been exposed to macrolides like clarithromycin are almost always susceptible. This is a very useful general rule for clinicians. It means they can usually start treatment with confidence that the macrolide will be effective initially. However, the utility of susceptibility tests for NTMs that have persisted beyond a course of antimicrobial therapy, for example, when deciding on next steps for a patient who isn't responding, is largely undetermined. This highlights a gap in our knowledge and a real challenge in managing chronic NTM infections that develop resistance over time.
Once diagnosed, what's the path forward to combat these persistent infections? Let's explore the strategies for control, covering both prevention and treatment.
Okay. For prevention, or prophylaxis, the clearest guideline is for MAS C disease in HIV-infected patients. Prophylaxis is started when the CD4 plus T lymphocyte count falls below 50 cells per microliter, indicating severe immune compromise. Effective drugs for this include azithromycin at 1,200 milligrams weekly, clarithromycin at 1,000 milligrams daily, or rifabutin at 300 milligrams daily. This has been a major success in preventing disseminated MSC in this vulnerable population.
And what about other immunodeficient patients? Our sources note that macrolide prophylaxis in immunodeficient patients susceptible to NTM, such as those with defects in the IFN-TIL12 axis we discussed, has not been prospectively validated. Does that mean it's not done?
It means that while large-scale clinical trials haven't definitively proven its effectiveness in these specific patient groups, it seems prudent given the known high susceptibility and the good track record in HIV patients. This suggests an area where further research could clarify clinical practice, but many clinicians might consider it on a case-by-case basis, weighing the risks and potential benefits.
Moving to the general principles of NTM treatment, it's important to remember that NTMs cause chronic infections that evolve relatively slowly over weeks to years. What does this mean for the urgency of treatment?
This means it's rarely necessary to initiate treatment on an emergent basis before a clear diagnosis is made and the infecting species is precisely known. This is a significant difference from many acute bacterial infections where you might start broad-spectrum antibiotics immediately. With NTM, you have the luxury and, frankly, the necessity of waiting for specific identification and sometimes susceptibility results to guide therapy properly. Rushing in isn't usually helpful.
But the flip side is that treatment of NTM is complex, often poorly tolerated by patients, and can be potentially toxic due to the long duration. And here's a critical warning, just as in tuberculosis. Inadequate single-drug therapy almost always leads to the emergence of antimicrobial resistance and ultimately relapse. Why is that such a strong warning?
Because NTM are tenacious survivors, if you hit them with only one drug, they have a knack for developing ways to become resistant fairly quickly. This makes future treatment much, much harder. This underscores the absolute need for multi-drug regimens combining several medications that attack the bacteria in different ways to prevent resistance from emerging and ensure the best chance of successful eradication. It's really non-negotiable for most NTM infections.
Let's delve into specific treatment regimens, starting with MSC infection. What's the foundation of therapy for MS?
The foundation of therapy for MAZ is multi-drug therapy, typically with a macrolide, either clarithromycin or azithromycin, along with ethambutol, and a rifamycin, which could be rifampin or rifabutin. That's the core combo. For disseminated NTM disease in HIV-infected patients, the use of rifamycins poses special problems because of known interactions with other HIV medications, particularly protease inhibitors. This necessitates careful drug selection and monitoring to avoid severe side effects or reduced efficacy of either set of drugs. It requires expertise.
For pulmonary ME disease, are there specific dosing strategies that have shown success?
Yes, for pulmonary Maze disease, a thrice-weekly administration of a macrolide or rifamycin and ethambutol has been shown to be quite successful and can sometimes improve tolerance. The duration of therapy is notoriously prolonged. Generally, it continues for 12 months after culture conversion, meaning after the cultures show no more bacteria.
12 months after conversion. Wow.
Exactly, which often means therapy typically lasts for at least 18 months in total, sometimes longer. It's a significant commitment for patients. Other drugs with activity against M-funky organisms include intravenous and aerosolized aminoglycosides, fluoroquinolones, and clofazimine, which can be added for more resistant or severe cases, or if the core drugs aren't tolerated.
It's a marathon, not a sprint, for these patients. Are there significant side effects to worry about with these prolonged regimens?
Yeah, it's definitely something to manage. It's worth noting that rifabutin can exert significant toxicity in elderly patients, particularly at higher doses, often causing joint pain or uveitis, which is inflammation of the eye. However, with only modest efforts in monitoring and dose adjustments, most antimycobacterial regimens are generally well tolerated by most patients. It requires active management, but it's usually feasible. Surgical intervention, such as resection of cavitary lesions or severely bronchiectatic segments, meaning removing the badly damaged lung tissue, has also been advocated for some patients, especially those with macrolide-resistant infections, as a way to reduce the bacterial burden that antibiotics can't reach effectively. The success rates for therapy for pulmonary amethy infections vary widely, from maybe 20% to 80%, depending on whether the disease is nodular or cavitary, and whether it's early or advanced stage. This highlights the challenge of these chronic infections.
Next, M. Kansasi lung disease. This infection sounds quite similar to tuberculosis in many ways, including its response to treatment. What's the typical regimen here?
You're right, it is remarkably similar in its response. M. Kansasi lung disease is effectively treated with a regimen of isoniazid at 300 milligrams per day, rifampin at 600 milligrams per day, and ethambutol at 15 milligrams per kilogram per day. Very similar to standard TB therapy. Other drugs with very high-level activity against M. Kansasi include clarithromycin, fluoroquinolones, and aminoglycosides, offering alternatives or additions for complex cases if needed.
How long does treatment typically last for M. Kansasi?
Treatment for M. Kansasi should continue until cultures have been negative for at least 1 year. The good news is that, in most instances, M. Kansasi infection is easily cured, making it one of the more responsive NTM infections, thankfully. What's fascinating here, and a connection to our earlier discussion on genetics, is that bulky, severe, necrotizing M. Kansasi lymphadenopathy, meaning it causes tissue death, especially in the mediastinum, the central chest cavity, is strongly associated with GATA2 deficiency. It highlights that specific genetic link again.
Now, rapidly growing mycobacteria, particularly M. abscessus, pose special therapeutic problems. How does treatment differ depending on whether the infection is localized or widespread?
They are notoriously difficult. For extrapulmonary disease in an immunocompetent host, often due to inoculation from surgery, injections, or trauma, or from a line infection, it's usually treated successfully with a macrolide and another drug. That second drug is chosen based on in vitro susceptibility testing, along with removal of the offending focus, like an infected catheter or implant. The key here is removing the source.
But what about pulmonary disease caused by M. abscessus? That sounds like a different beast entirely.
Oh, it is. In contrast, pulmonary disease caused by M. abscessus is extremely difficult to cure. Repeated courses of treatment are usually effective in reducing the infectious burden and symptoms, but often not eradicating the infection entirely. It's more about control than cure sometimes. Therapy generally includes a macrolide, along with an intravenously administered agent such as amikacin, a carbapenem, cefoxitin, or tigecycline for an initial intensive phase, often lasting weeks or months. Oral agents used for maintenance therapy according to in vitro susceptibility testing and patient tolerance include fluoroquinolones, doxycycline, linezolid, and newer tetracycline family drugs like omadacycline and eravacycline. It's a complex long-term strategy.
Because NTM infections are chronic, care must be taken with long-term use of drugs that have neurotoxicities, like nerve damage, such as linezolid and ethambutol. Are there ways to mitigate these?
Yes, very much so. These are real concerns with long-term use. For example, prophylactic pyridoxine, which is vitamin B6, has even been suggested in these cases to help prevent some of the neurological side effects of certain drugs like isoniazid and linezolid. The durations of therapy for M. abscessus lung disease are notoriously prolonged and complex, often requiring the guidance of experts due to the challenging nature of these infections and the potential for severe side effects. It's not straightforward.
For M. marinum infection, how responsive is it to treatment?
Once recognized, M. marinum infection is highly responsive to antimicrobial therapy and is cured relatively easily, thankfully. Makes a nice change. Treatment typically involves any combination of a macrolide, ethambutol, and erythromycin. Therapy should continue for 1 to 2 months after clinical resolution for isolated soft tissue disease. However, tendon and bone involvement may require longer courses based on clinical evolution given the deeper nature of the infection. Other drugs with activity against M. marinum include sulfonamides, trimethoprim sulfamethoxazole, doxycycline, and minocycline, offering good alternatives.
And for other NTMs not specifically mentioned, where treatment might be less defined, what's the general approach?
For other rarer NTMs, the treatment is less well-defined, as you say. But macrolides and aminoglycosides are usually effective against many of them, with other agents added as indicated by the specific species and susceptibility patterns discovered in the lab, if available. Given the complexity and variability across the huge number of NTM species, our sources strongly encourage expert consultation for difficult or unusual NTM infections. This isn't really a condition for generalists to tackle alone without specialized advice. Consulting with infectious disease specialists or mycobacterial experts is truly paramount for optimal patient outcomes. Don't go it alone.
So we've navigated the complexities of diagnosis and treatment for NTMs. Now let's look ahead. What's the ultimate outcome for patients facing these varied infections, and how do global considerations play into the future of NTM diagnosis? Let's talk prognosis.
Okay. The outcomes of non-tuberculous mycobacterial infections are closely tied to the underlying condition that predisposed the patient in the first place, like an IFN-IL-12 pathway defect or cystic fibrosis. The prognosis can range widely from full recovery to, unfortunately, death in severe untreated cases or those with profound immune defects.
When left untreated or inadequately treated, the symptoms and signs can be truly debilitating. We're talking about persistent cough, fever, anorexia leading to significant weight loss, and severe lung destruction. However, with appropriate treatment, patients typically regain strength and energy, which is a very positive sign. Is there still a lingering question about optimal treatment duration?
Yes, there's still a critical, lingering question. The optimal duration of therapy when NTMs persist in sputum cultures, even after treatment initiation, is largely unknown. Do you keep treating? For how long? In these situations, treatment can be extremely prolonged, lasting years, and it becomes a balance between controlling symptoms and managing drug toxicities. It's a tough clinical decision. For severe underlying immunodeficiencies, hematopoietic stem cell transplantation, essentially replacing a faulty immune system, is recommended and can be very helpful in the resolution of severe mycobacterial disease, offering a chance for a new, healthier immune response. But that's a major intervention.
This leads us to crucial global considerations that really highlight how NTMs are changing the landscape of mycobacterial disease. In many countries, pulmonary tuberculosis is still diagnosed by smear alone, and this same method is often used for monitoring treatment response and relapse. What hidden problem has this simple reliance on smears revealed?
Yeah, this is a huge issue. A significant hidden problem has been revealed. When mycobacteria from relapsed TB patients are examined more closely with advanced diagnostic techniques like culture and speciation, a substantial proportion of those isolates are actually NTMs, not M. tuberculosis. They were never TB relapse cases in the first place.
This has a huge impact on public health data, doesn't it?
Yeah.
If a significant portion of relapsed TB isn't actually TB, then our understanding of TB control and resistance is flawed.
Precisely. Overall, as rates of true M. tuberculosis decline globally, the proportion of positive smears that are actually caused by NTMs will inevitably increase. This makes accurate identification even more critical, both for individual patient treatment and for global disease surveillance. If you're treating an NTM as if it's TB, you're using the wrong drugs, potentially for a very long time, and you're misclassifying the epidemiology.
So what's the promising outlook here for diagnosis, and how will it impact global public health moving forward?
Well, the promising outlook here is that advances in speciation, like the DNA sequencing methods and other molecular techniques we discussed, will increasingly distinguish M. tuberculosis from NTM infections, even in resource-limited settings eventually. This is vital because it will directly affect the assumed rates of TB relapse and resistance, giving us a far more accurate picture of the true burden of both diseases. Ultimately, it will lead to more targeted and appropriate therapy for patients, ensuring they get the right drugs for the right bug. That's foundational to good medical practice and robust global public health. It corrects our understanding.
What a journey through the world of non-tuberculous mycobacteria. It's truly fascinating to see how something so ubiquitous in our environment can, under specific circumstances, become such a challenging and complex health issue.
It really does highlight the intricate balance of our immune system, the incredible adaptability of these microorganisms, and the critical role of advanced diagnostics in a world grappling with, well, just a ton of information. Recognizing the nuances between different mycobacterial infections isn't just an academic exercise, it directly impacts patient care globally, and it's a field where our understanding continues to deepen almost daily.
Absolutely. And this shift in disease patterns, with NTMs becoming more prevalent than TB in some regions, reminds us that public health landscapes are always evolving. They demand constant vigilance and adaptability from us. So what does this all mean for you, our curious listener?
I think it means that the seemingly hidden diseases, like NTMs, require constant vigilance and ongoing research. The goal isn't just to cure the immediate infection, but to understand the underlying vulnerabilities, whether they're genetic or environmental, that allow these organisms to take hold in the first place. It's about moving beyond symptoms to truly grasp the complex interplay of host, pathogen, and environment.
And as we wrap up this deep dive, here's a final thought for you to mull over. As we get better and better at identifying NTMs, will we also discover even more genetic predispositions or environmental factors that fundamentally shift our understanding of who is truly at risk? Or will these incredibly adaptable organisms simply continue to evolve faster than our diagnostic tools, presenting new challenges down the line? Something to ponder until our next deep dive. Thanks for joining us on this deep dive. If you're as fascinated by uncovering these layers of knowledge as we are, be sure to join us again for more shortcuts to being well informed.